Welcome to the first lecture in your Specialist in Exercise Therapy course. In this lecture, we will start by discussing the history of therapeutic exercise. We will then move into how exercise therapy has evolved, discuss the benefits of exercise and the impact of disuse, and finish up with program considerations and your role in restorative health. Let's get started. The traditional model of medicine was, if something went wrong, a doctor would fix it. As time progressed, we saw a growth in preventive medicine. Before World War II, physical therapy generally consisted of heat, massage, or electricity. If exercise was prescribed, the prescription was vague. During World War II, many VA hospitals employed physical medicine physicians to rehabilitate injured soldiers using corrective exercise. This was the advent of proactive rehabilitation. We now know that a properly designed exercise program can have a positive impact on the outcome of most conditions. Before managed healthcare, patients could continue physical therapy until they were completely restored. Unfortunately for most of us, that paradigm no longer exists. Also, a large percentage of physical therapy focuses more on rehab of acute injuries and less on managing chronic conditions. Specialists in exercise therapy can play a major role in both of these areas, bridging the gap from rehab to restoration and helping to manage chronic conditions through appropriate exercise programs. Therapeutic exercise can range from very specific selected activities designed for a particular muscle or condition to general and vigorous movements designed to restore an athlete to peak performance. The application of therapeutic exercise varies in purpose according to client goals. The role of an exercise therapy program is to increase functional fitness without exacerbating existing conditions. A well-designed program allows clients with disabilities to develop and maintain fitness and posture, increase psychomotor skills, maintain the skills acquired in physical therapy and post-rehab, and provide clients with the opportunity to achieve their greatest overall potential. A proper therapeutic exercise program will be designed to prevent further dysfunction and should strive to foster improvement, restoration, or maintenance of muscular strength and endurance, cardiovascular and cardiorespiratory fitness, mobility, flexibility, range of motion, agility, balance, stability, coordination, functional skills, and activities of daily living. Exercise is especially appropriate for clients with disabling conditions for a myriad of reasons. Therapeutic exercise can relieve symptoms and improve function. An adaptive program can provide the opportunity to participate in activities that are not otherwise easily performed and can improve fitness, mobility, and self-efficacy. Attitudes toward persons with disabilities are often reflected in the labels used to identify and group them. Medical labels do have some benefit, but incorrect or improper use of labels can stigmatize individuals and groups. Stigmatization generates sympathy or fear towards persons with disabilities, and of course is not desirable. Let's take a look at a few terms that have historically influenced attitudes and could use some differentiation. Handicap and disability. Though used interchangeably in both everyday conversation and more formal settings, like legislation and education, these terms are not synonymous. Handicap is generally defined as a condition that restricts a person's ability to function physically, mentally, or emotionally. A person is handicapped if he encounters impediments or disadvantages that limit success in a given situation. Thus, being handicapped is situation-specific. That is, a person may be handicapped in one situation, but not in others. In contrast, the term disability most commonly refers to the presence of a medical condition. Disabilities, of course, can also restrict the ability to perform activities of daily living, but they do not necessarily render a person handicapped in all situations. Let's look at a specific example. A client may have a disability because of a spinal cord injury, leaving the individual disabled or paralyzed in the leg muscles. This person is handicapped if stairs are the only means to get to the second floor. If an elevator is available, however, then no handicap exists, because the individual is able to accomplish the objective of getting to the second floor. And this same person may not be handicapped in other areas at all, say in archery, for example. Another phrase you will encounter in exercise therapy is functional limitation. Functional limitations are conditions that are not as thoroughly disabling, yet become more obvious or acute when performing a specific activity. Functional limitation may be more useful than disability because it is more descriptive and less imposing. We can show respect for our clients in other word choices as well. When speaking about a client's condition, describe the client first and the condition second. For example, it is less desirable to use the term epileptic than the phrase person with epilepsy. The former defines the person in terms of her condition, while the latter places individuality first. It is valid to assume that, taken as a total human being, a person with a disability can do more than she cannot do. Any of the terms we use to discuss or describe disabilities can have negative connotations, and some terms have been and continue to be used incorrectly. Pay close attention to how your clients refer to their conditions, and use the terms that they use. Easier still, ask them which terms they prefer. Always focus on the person first, and on the condition second. And when in doubt, turn your attention to the client's abilities. For more information on respectful language, let's turn to Mobility International USA. MIUSA's mission is to empower people with disabilities to achieve their human rights through international exchange. Here are some common guidelines released by MIUSA for talking about a person's disability. These guidelines, along with other important information, can be found at www.miusa.org/ncde/tools/respect. You can follow this link directly in Week 1's web links. The first of MIUSA's general guidelines is to refer to a person's disability only when it is related to what you're talking about. When talking about places with accommodations for people with disabilities, use the term accessible rather than disabled or handicapped. For example, refer to an accessible parking space rather than a disabled or handicapped parking space, or an accessible bathroom stall rather than a handicapped bathroom stall. Use the term disability and take the following terms out of your vocabulary when talking about or talking to people with disabilities. Avoid the terms handicapped, differently abled, crippled, victim, retarded, stricken, poor, or unfortunate. Just because someone has a disability, it doesn't necessarily mean he or she is courageous, brave, special, or superhuman. People with disabilities are the same as everyone else. It's okay to use words or phrases such as disabled, disability, or people with disabilities when talking about disability issues. Ask the people you are with which term they prefer if they have a disability. When talking about people without disabilities, it is okay to say people without disabilities, but do not refer to them as normal or healthy. These terms can make people with disabilities feel as though there is something wrong with them and that they are abnormal. When in doubt, call a person with a disability by his or her name. As our society ages, more and more individuals are acquiring disabling conditions. More than 4 out of 5 people over the age of 65 have at least one chronic condition. The most prevalent chronic conditions seen in older people include arthritis, hypertension, hearing impairments, heart disease, vision loss, and various orthopedic conditions. Most of the things that cause disease and accelerate aging can be positively influenced with the proper dose of therapeutic exercise, whether as a preventive measure or as a restorative tool. Hippocrates knew this in 370 BC. He is known to have said, generally speaking, all parts of the body that have function, if used in moderation and exercised in labors to which each is accustomed, become healthy and well-developed and age slowly. But if unused and left idle, become liable to disease, defective in growth, and age quickly. Said another way, use it or lose it. Most of us agree with those statements. Unfortunately, it took 2,000 years for the scientific community to prove it. Exercise affects the majority of the body's tissues, organs, and systems to bring about homeostatic stability and normal function. The body was designed to move. It might seem logical that someone that is recovering should be resting in bed, but researchers in Australia reviewed numerous studies and found that complete bed rest actually delays or complicates recovery. The deleterious effects of disuse syndrome illuminate the importance of exercise for individuals who are recovering from injury or managing chronic conditions. Disuse syndrome results from disruption of the normal balance between rest and physical activity, thereby decreasing the optimal functional capacity of an individual. Depending on the organ or system involved, disuse syndrome can develop within as little as 3 days of immobilization. If you are a sports fan, you'll be familiar with this concept. Rehabilitation is central to getting back on the playing field. Most athletes are not told to rest until they are completely healed. Instead, they are proactively involved in the healing process. Your role will be to facilitate restoration so that your clients can function at maximum ability. Medical complications of disuse syndrome are numerous. The physiological and biochemical changes in organs and systems of the body produced by disuse include decreased physical work capacity, muscle atrophy, negative nitrogen and protein balance, osteoporosis, contracture of connective tissue, cardiovascular deconditioning, pulmonary restrictions, decubitus ulcer, mental depression, and loss of self-esteem. When disuse syndrome is coupled with a disability and aging, the result is more functional loss than would be predicted by the disability alone. And the greater the loss in functional capacity, the greater the loss of independence in activities of daily living. Thus, the more negative impact the condition will have on the lifestyle. Exercise can prevent, minimize, or reverse the effects of disuse syndrome, even if disabilities are severe. Unfortunately, many Americans who suffer from chronic conditions fall through the cracks. They are not acutely ill, but they are not well enough to function optimally. This large and important segment of the population can greatly benefit from the skills and expertise of the specialist in exercise therapy. The specialist in exercise therapy, working in concert with medical professionals, can make a significant and positive impact in their clients' quality of life. Let's talk now about the benefits of exercise. The benefits of increased physical activity include the maintenance of optimal health, a decrease in the incidence of secondary health problems related to disuse, increased muscular strength and endurance, increased flexibility, and improvement in cardiovascular function. The risk factors responsible for cardiovascular disease are reduced, as are glucose intolerance and obesity. Increased physical activity also reduces depression, improves sleep, enhances self-esteem and a feeling of control, improves basic motor skills, makes activities of daily living, or ADLs, easier. Let's take a closer look at how exercise impacts specific aspects of health. Mental capacity. As mentioned, physical activity has been shown to decrease depression, but it also improves mental sharpness. Cardiorespiratory and cardiovascular function. Heart, lung, and circulatory function have been well documented to improve with proper training. Liver function. Cardiovascular conditioning improves the ability to store liver glycogen. Metabolism. Physical activity increases the body's metabolism. Strength training increases muscle mass, which elevates metabolism as well. Body composition. Proper exercise, along with proper caloric consumption, improves lean body mass quotients. Musculoskeletal system. Most sedentary older adults have lost a large amount of strength and muscle mass by age 70. This loss of muscle is responsible for many older adults losing their ability to maintain their independence. Bone density. Adequate stimulation has been shown to maintain and, in some cases, increase bone density. Gastrointestinal function. Physical activity may decrease colon cancer, because physical movement decreases the time food is in the colon and rectum. Finally, physical activity impacts immune function. Research shows that mild to moderate exercise improves T-cell production and strengthens immune response. Do note, however, that vigorous exercise has been shown to decrease immune function. This is one of the many good reasons to progress slowly and to set up a program that provides benefits without overtraining. Current evidence suggests that people with disabilities can benefit from a sensible exercise routine. Exercise therapy can be enjoyed by virtually anyone with a disability, but it is especially appropriate for people with orthopedic and joint dysfunctions. Persons with obesity, ambulatory limitations, and low back syndrome conditions do extremely well within an adaptive aquatic setting. There are only a few conditions for which an exercise program would be contraindicated. These are summarized in the exercise participation flowchart included in Chapter 5 of your text. Remember, even if exercise is not contraindicated for a specific condition, it is always prudent to have the client's physician give approval before the client undertakes an exercise program or engages in a new activity. Along with documented health benefits, it also appears that exercise and physical activity can be used to prevent, control, rehab, and restore a particular condition. This table outlines some of those conditions along with age recommendations. Therapists and rehab specialists have known for years that the proper dose of exercise is useful in restoration. Research now suggests a great many diseases and chronic conditions can be positively influenced with regular, sensible, and systematic exercise. The Design for Action table in your text is another resource for this topic. The table summarizes the data available on the impact exercise has on various conditions. One of the important aspects of therapeutic exercise is to find the right amount of exercise, an amount that will produce benefits without overtraining. More is not always better, and what is right for one person may not be right for the next person. Exercise physiologists continue to grapple with this challenge. Currently, fitness experts are trying to determine the correct dosage of exercise for different conditions. This concept is not unlike finding the correct prescription medication. The goal is to find an amount of exercise that produces the maximum benefit without any undesirable side effects. Your role as specialist in exercise therapy is to provide safe and appropriate exercise that will not aggravate the client's existing condition. As an exercise therapy professional, it is imperative that you are aware of your role and scope of practice. It is not your duty to diagnose conditions nor to prescribe therapy. It is your responsibility to make sure that the exercises performed will not exacerbate a client's condition and will complement those activities assigned by the client's therapist, physician, or chiropractor. Exercise is much like medication. It must be applied appropriately and monitored. Keep the lines of communication open between yourself and health professionals. When in doubt, refer the client back to the medical community. In order to avoid a lawsuit, know your scope of practice and stay within it. When you begin working with clients with disabilities, it is essential to begin with a proper medical evaluation and assessment by your client's physician, physical therapist, or better yet, both. Consult the professional on the client's prognosis, any functional limitations that might be present, realistic expectations and client gains, exercises to avoid, and any medical precautions or other considerations. This is an extremely important step that will protect your client's health, functionality, and gains. It will also protect you as a fitness professional. In addition to the consultation and recommendations of a qualified medical professional, here are the other factors around which you will design your program. Of course, the client's specific condition, the client's age, previous conditions the client has had, any corresponding precautions for previous conditions, the psychological and socioeconomic status of your client's physical environment, your client's emotional environment, and the cultural reactions and expectations your client may experience because of his or her condition. Trainers working in exercise therapy must be at the top of their profession. They must rely on sound scientific knowledge and must be thoroughly versed in proper biomechanics, safe fitness movement, sound nutrition, current exercise science, and adhere to a strong code of ethics. No one is more vulnerable than someone who desires to be healthy again. The exercise therapy arena is not a place where you can fake it until you make it. Incorrect moves and misinformation are serious enough for clients without disabilities. A mistake with clients that have acute or chronic conditions can have serious ramifications. If you have any questions or concerns, err on the side of caution and refer out. And always check your sources. What is correct today can change tomorrow. Train clients smart, not hard, and remind clients to be patient. Clients with acute and chronic conditions have likely invested a great deal of time and money on doctor's visits, surgery, and physical therapy. You do not want to undo all that they have done by being hasty, misinformed, or careless. Nearly all chronic conditions can be positively influenced by proper exercise and a caring instructor. If you desire to be an effective teacher of the physically limited, you must be willing to research, adapt, and modify until your client is successful. We talked about getting a medical professional's opinion before initiating training, but it's also important to know when to seek medical attention during the training relationship. Symptoms of concern include shortness of breath, dizziness, numbness in the chest or arm, jaw pain, persistence or gradual increase of soreness or discomfort, decreased active range of motion, swelling, redness, point tenderness, an increase in the number of symptoms your client exudes or an increase in symptom intensity, and lack of progress. If you observe any of these signs, refer your client to a medical professional. What's more, refer to a medical professional anytime you have concerns about a client's progress or condition. It is always better to be safe than sorry. Safe than sorry. Safe than sorry. Today, we're going to finish up our overview of functional fitness, and then we're going to start getting down to the nitty-gritty with topics and the fundamentals of exercise therapy. The major reason why people come to rehabilitation is to return to a pain-free, active lifestyle. The first and immediate reason for rehabilitation is to resolve the clinical symptoms that exist after an insult to a part of the body. Appropriate medication, physical modalities, relative rest, and even immobilization are employed in the early phase of rehabilitation. If the pathology warrants, surgical procedures may also be necessary. Most people demand more than just relief of symptoms. Most want full restoration of function. Restoration of function needs to address local and general effects of the injury or condition. It is well documented that muscular strength can decrease by 17% within 72 hours of immobilization and decrease up to 40% after 6 weeks of casting. VO2 max decreases by 25% after 3 weeks of bed rest. A total functional fitness program is aimed at assisting the injured part back to health while minimizing deconditioning of unaffected parts and systems. Another goal is to restore the client to a level of fitness that is as close as possible to the level enjoyed before the injury or onset of condition. Do realize, however, that it is more important to measure progress and success by the ability of the client to participate in activities of daily living, ADLs, over achieving a specific ROM or other statistical measure of fitness. Functional exercise refers to exercises and activities that mimic movements and patterns required to perform ADLs. Functional exercise is simply the application of the specific adaptation to imposed demands principle, or SEID principle. Muscles will adapt specifically to a specific type of demand placed upon them. Functional exercise is like specificity of training for a particular sport, except in this case, it is the sport of living. Functional exercise should consider: what is the role of the muscle or joint? Is it a mover? Is it a stabilizer? Is it weight-bearing or not? Is the muscle too tight or too weak? Is the neuromuscular unit intact? Was the muscle fully functional before the injury or onset of condition? To make an exercise program as functional as possible, train the muscles in ways, methods, and roles that mimic daily living. An example often used in football is, just because a lineman can bench 300 pounds doesn't mean the lineman can protect the quarterback. So it is with functional fitness. A 160-degree range of motion in the shoulder does not necessarily translate into the ability to return to work as a painter and function fully. In functional training, the plan is to gradually progress from simple to complex, and from isolation-type moves at a single joint to movements that employ several joints and muscle groups and stabilizers. Here are some important keys to proper functional exercise. Simple before complex. Based on this point, the remaining points are quite obvious. Static before dynamic. Slow before fast. Low force before high force. 2 arms before single arm. 2 legs before single leg. Stable surface before introducing unstable surface. Quality movements before quantity of movements. Focus on core of trunk as well as stabilizers of each joint. Correct usage of open kinetic change before utilizing closed kinetic change exercise. Proper usage of concentric, eccentric, isometric, isokinetic, and plyometric moves. Remember to individualize. Not all of these points apply to every condition or to every client. Don't go outside your scope of practice and expertise, and seek advice as needed. Now that we have wrapped up our overview, let's move on to the meat of the course. Whether disabilities are congenital or acquired, whether a person is young or old, rich or poor, participants can all benefit from a fitness therapy program. The question of how exercise is beneficial to the person with a disability can best be explained by again considering the deleterious effects of a sedentary lifestyle, or disuse syndrome. Disuse syndrome results from disruption of a normal balance between rest and physical activity, thereby decreasing the optimal functional capacity of an individual. Inactivity reduces the opportunity for active muscle contractions and diminishes the influence of gravity on weight-bearing bones. Depending on the organ or system involved, disuse syndrome can develop within as little as 3 days of immobilization. Medical complications of disuse syndrome are numerous, producing deleterious changes in organs and systems of the body. As discussed in our last lecture, when a disability is coupled with disuse syndrome and aging, the result is a greater functional loss than would be predicted by the disability alone. The greater the loss in functional capacity, the greater the loss of independence in activities of daily living. Thus, the more negative impact that condition will have on lifestyle. Exercise can prevent, minimize, or even reverse the effects of disuse syndrome, and should be available to all persons with disabilities, even if those disabilities are severe. Although exercise may vary in type and mode, all forms of exercise provide some degree of mental and physical benefits. Designing a safe and appropriate individualized exercise program is the goal of a fitness therapy instructor. The more information you have about the client, the more effective and safer the program design will be. Following these principles will improve your effectiveness as well as your credibility within the health community. Gather basic information for each client. All clients, regardless of age, should have medical clearance to participate. If the client is being seen by more than one health professional, be sure to have medical clearance from each. Pre-test the client's functional abilities and limitations. Compile a listing of all prior and existing medical conditions. Establish a baseline of resting blood pressure and pulse. Have an emergency plan and contact phone number. Record all medications the client takes along with their side effects. Be aware of your client's wishes regarding a do not resuscitate DNR order. Formulate and record recommended and contraindicated exercises. Finally, and this may seem obvious, if you are employed by or engaged in a contract with a facility, follow the facility's rules for conduct, record keeping, and safety. Now you are ready to start designing an exercise program. When designing an exercise program, keep the following in mind. Safety. Safety is a top priority in an exercise therapy program, for the clients as well as the staff. Always try to anticipate any type of accident before it occurs. Be alert to all clients' physical and cognitive ability levels each day. Constantly monitor the room and equipment for possible hazards. Prevention of falls is of prime importance. Check to see that electrical cords are placed out of walking paths, small pieces of equipment are not left on the floor, and that there is adequate room to maneuver, especially if clients employ the use of canes or walkers. Medication. All clients engaging in exercise therapy should know and report what medications they are taking and their potential side effects. Clients prone to angina or chest pain likely carry nitroglycerin tablets and take as needed. Clients with diabetes likely carry candy or another sugary item in case of a drop in blood sugar. You can also keep small cans of juice next to the first aid kit for emergency purposes. At times, a client's health status may require his or her physician to prescribe a new drug, and thus the adjustment period may take some trial and error. In terms of participation during an exercise class, clients should be observed for signs of fatigue, breathlessness, dizziness, listlessness, and general malaise. Communication. Being able to personally interact and communicate with another individual and having a positive impact on his or her life is one of the most rewarding experiences you can have. Here are some suggestions to help you develop a more professional working relationship with your clients. Make eye contact with the person and remember the person's name. Express a sincere interest in the person you are working with. A warm and friendly manner puts everyone at ease. Be aware that your attitude can be a motivating force for others. Respect your client's privacy at all times. Focus on the task at hand. An experienced professional has learned how to separate work and personal issues. The key is to remember that you are here for the client's benefit, not your own. You should not impose your personal worries on the client. On occasion, you may also have to gently remind the client that he or she is here to exercise and not dwell on outside issues. Determine how each client learns best. Face the person and be sure to speak clearly and efficiently. Some understand better by seeing you demonstrate, others by following verbal directions. Clients with limited vision may also benefit by your hands-on guidance. Provide feedback about how the client is doing. Be encouraging and try to make any criticism constructive. Remember, you can always learn from clients too. An important point to remember is to allow the clients to do as much as possible for themselves. Even if something, such as putting on a jacket, is a struggle, encourage the client to keep trying. Of course, always use your best judgment based upon the entire situation at the time. Encourage feedback from the clients on how to improve the program and make it more enjoyable. And finally, evaluate yourself periodically to see how you have enhanced your performance in terms of self-confidence, general knowledge, leadership, and personal interaction skills. Fitness evaluation. Physical assessment of the participant provides data that allows you to establish the client's current level of performance, identify realistic and individualized exercise goals, prescribe appropriate adapted exercises, and monitor. The assessment should begin by jointly determining the client's long-term and short-term goals. Information provided on the medical release and intake forms, as well as the client's own goals, direct the type of assessment that needs to be conducted. The exercise card. Once the medical history and release have been obtained and the physical assessment has been completed, the task of individualized exercise programming may begin. Assessment data should be blended with the client's medical history, type and severity of disability, age, personal long-term and short-term goals, and the physician's recommendations to produce an individualized exercise program. Ideally, the medical release should be updated every year at a minimum. Any significant change in the client's medical condition would also warrant an updated medical release from the client's physician. For liability purposes, maintain the client's file until the statute of limitations runs out on a person's right to litigate for negligence. You can write out each individual's entire exercise program on cards, or store the program in your computer. Here's a list of information to maintain. The client's name. Recorded dates for every day the client exercises. Names of exercises, techniques, and body positions used. Daily recording of quantitative data related to performance. For example, the number of sets, repetitions, and weight lifted for strength exercises. Resting and exercising heart rates. Resting and exercising blood pressures. Duration of exercise. And work rates for cardiovascular training. Any exercise contraindications or precautions. Medical conditions, and medications. In addition, include progress notes to record qualitative information, for example, pain occurring during an exercise, observations regarding the client's response to the session, and progress toward goals. Let's take a look at body mechanics. We'll begin with a quick review of the anatomy of the back. Your back consists of a column of individual bones, or vertebrae, separated by cushions, or discs, and held together by joints, ligaments, and muscles. It supports your upper body, protects your spinal cord, and allows you to move freely. The healthy spine is made up of 24 vertebrae aligned in 3 natural curves: the cervical curve of your neck, the thoracic curve of your middle back, and the lumbar curve of your lower back. When you maintain these 3 natural curves in their normal alignment, your weight is evenly distributed throughout the vertebrae and discs. This minimizes your vulnerability to injury. The 3 curves are correctly aligned when your ears, shoulders, and hips are in a straight line. With poor body mechanics, lifting even a slight weight can put an excessive strain on your lower back. Do not reach and bend from the waist. This forces your back to support your upper body in addition to the load. Poor body mechanics over time can cause disc damage and pain, and lead to a herniated disc. Healthy discs are shock-absorbing pads located between the vertebrae. They consist of a jelly-like center surrounded by a tough, fibrous ring. A herniated disc occurs when pressure on the front of the disc squeezes its jelly-like center out the back or side. This puts pressure on the spinal curve and causes pain. Here are some tips that reduce the risk of back injury for both your clients and you as you work with clients that may need more of your physical assistance. When you lift a load close to your body, you give yourself leverage that reduces the strain on your lower back. By keeping your 3 natural curves aligned, you distribute the weight of the load evenly throughout your spine, lowering the risk of injury. By contracting your abdominal muscles, you reduce pressure on the spine and maintain your lumbar spinal curve. Lifting is a common cause of back injury, so always keep the load close to the body. Bend the knees and hips. Tighten the abdominal muscles during the lift. Lift with the legs and buttocks. Maintain the 3 natural curves of the back. And avoid twisting your back while lifting. Lift first and then pivot on your feet. Reaching, especially in high places, can injure the back if you reach too far or lift too much weight. To reduce the risk of injury caused by reaching, avoid lifting objects above the head or below the knees. Reach only as high as is comfortable. Do not stretch. Use a stool if necessary. Test the weight of the load before lifting by pushing up one corner. Let your arms and legs do the work, not your back. Tighten your abdominal muscles as you lift. Pushing and pulling large objects can be as hard on the back as heavy lifting. Remember to stay close to the load. Don't lean forward. Whenever possible, push rather than pull. You can push with twice as much force as you can pull. Use both arms. Tighten your abdominal muscles when pushing. When you perform a task that requires prolonged standing, you may slouch and forget to maintain your 3 natural curves. This bad posture can cause muscle tension, stiffness, fatigue, backache, and neck ache. It also contributes to degeneration of discs and ligaments. To maintain good posture, stand close to the person so you don't have to lean forward. Bend with your knees and maintain your back's 3 natural curves. Maintain neutral spine technique, or pull up a chair to talk with someone who is seated. People fall for many reasons. They may be afraid or become dizzy, or their knees may buckle. When someone starts to fall, guide the person easily and safely to the floor, bending your knees, not your back. Don't try to prevent the fall, or you may injure yourself. Stay close to the person. Mentally practice this maneuver before an accident actually happens. Then physically practice on someone simulating a fall. Practice maneuvers in several positions on various sides of the person's body. Lastly, use proper lifting techniques all the time, whether lifting a pen or a person, so that it's automatic when you must do it suddenly. Optimal learning occurs when the teaching style is congruent with the characteristics of the learner. No single teaching style, strategy, approach, or method is a remedy for all instructional situations. Effective teachers appropriately adapt teaching styles to match the various learning styles of their students. In adaptive programs, instructors are faced with the challenge of facilitating learning for a group of individuals who possess various disabling conditions and learning styles. Understanding the learning process in these situations is crucial and means the difference between mediocre and effective programs. We are now going to review the different learning styles one may encounter in adaptive programs and present instructional strategies for facilitating optimal learning. There are numerous principles that affect the client's rate and amount of learning. The teacher must understand these principles to be successful and effective. The principle of pleasurable effect. Clients tend to accept and repeat those responses that are pleasant and satisfying, and avoid those which are not. The principle of nothing succeeds like success. Make every effort to see that clients achieve some success during each class. The principle of primacy. First impressions are lasting. Make those initial meetings meaningful. The principle of practice and repetition. The more often an act is repeated, the quicker the skill is established. The principle of disuse. A skill not practiced or knowledge not used will be forgotten quickly. Important skills and concepts need to be reviewed. The principle of vigor. A dramatic or exciting learning experience is more likely to be remembered than a routine or boring experience. Let your teaching come alive. Use vivid examples and participate with the clients. Remember that humor is a useful teaching tool. Each individual, whether disabled or not, has a preferential learning style involving a dominant sensory channel. To foster the learning experience, you need to know the learning style of each client. This table will provide clues to decide if a client is primarily a visual, auditory, or kinesthetic learner. A client will learn more quickly when taught through the dominant sensory mode. You can find this table on page 35 of your text. Please take the time to review it after this lecture. The importance of trainer-client interactions cannot be overemphasized. The primary function of the trainer is to hasten the client's cognitive, psychomotor, and affective development as they relate to physical fitness. Trainers should be aware of the types of interactions that foster the client's learning, motivation to exercise, and attendance. If the client learns best within the visual domain, demonstrate a skill whenever possible. Tell the clients what to look for in your demonstrations. Maintain eye contact when speaking to clients. Use diagrams if necessary. Use visual cues to enhance body awareness and coordinated movement. For example, footprints placed on the floor, stickers placed on the body or equipment, pointing to a body part, or arrows on the floor. If the client learns best within the auditory domain, verbally direct the client to perform a task. Allow clients with hearing impairments to see your mouth and hand gestures. Do not over-exaggerate mouth movements. Provide corrective skill feedback. This consists of providing steps to correct an inadequate performance. Provide positive skill feedback. Tell clients what they did correctly to reinforce the likelihood of the skill being correctly performed again. Ask questions regarding discomfort during exercises. Listen to the client's questions, responses, or attempts at conversation. Use simple verbal cues to assist the client in better visualizing the movement. if the client learns best within the kinesthetic domain. Manually guide a client with a visual impairment through the desired motions. Physically assist a client whenever needed, and tap the body part to facilitate movement in the correct direction. If a client has a weak sensory channel, visual, auditory, or kinesthetic, then a multi-sensory approach may be warranted. This approach makes use of all the senses to promote and reinforce the learning of knowledge or skills. This concludes our lecture this week. Next time, we will discuss muscles and movements, as well as contraindicated exercises. Welcome to the next lecture in your Specialist in Exercise Therapy course. In this lecture, we will start by discussing kinesiology. This lecture will provide a foundation for anyone who has not taken a course in kinesiology, and will serve as a refresher course for those who have. We will then begin discussing topics on contraindicated exercises. Let's get started. Anatomical movements are always described in reference to the anatomical position. In this position, the individual stands erect, feet together, with the arms at the sides and palms facing forward. There are three factors that account for the stability of a joint. Muscles, such as the rotator cuff muscles of the glenohumeral joint. Shape of articular surface, such as the ball and socket construction of the hip joint. Ligaments, such as the anterior cruciate ligament in the knee area. Ligaments are tough and practically non-elastic. Ligaments hold bone to bone. Ligaments are generally found where more joint stability is needed. Ligaments restrain undesirable motion, for example, preventing side-to-side motion in the knee. Ligaments will yield to continuous regular stretching. This is why full squats and the hurdler stretch are controversial. Muscles can do only two things: develop tension or relax. It is important to remember that muscles can function individually or as a member of a team. While muscle movement can be isolated, most of the time there are several muscles involved to stabilize other areas or assist in the movement. A mover or agonist is a muscle responsible for concentric muscle actions. Movers are often subclassified as prime movers or as assistant or secondary movers for a given action. Prime movers are primarily responsible for eliciting a specific joint action. Assistant movers can be a muscle or a group of muscles that aid the prime mover in effecting joint movement. An antagonist is a muscle that produces an action exactly opposite of the agonist. An example of this is that the biceps brachii is an antagonist for the triceps brachii during elbow extension, and vice versa during elbow flexion. A fixator or stabilizer is a muscle that anchors, steadies, or supports a bone or body part to enable another muscle to have a firm base upon which to pull. A neutralizer is a muscle that contracts in order to counteract, rule out, or neutralize an undesired action of another muscle acting upon that joint. Finally, a synergist is a helper muscle. In kinesiology, the term contraction or action refers to the development of tension within a muscle. It does not necessarily imply that any noticeable shortening or movement occurs at the joint. There are three different types of muscular contraction. Static or isometric contraction occurs when a muscle does not develop enough tension to cause movement to occur in a joint. Thus, the length of the muscle remains unchanged. Technically, because the muscle remains at the same length, there is no internal shortening of contractile components, as in pushing the hands together. Concentric contraction occurs when a muscle develops sufficient tension to overcome resistance. The muscle visibly shortens and joint movement occurs, as in bringing your hand to your face. Flexing at the elbow joint is an example of a concentric contraction of the biceps brachii. Eccentric contraction occurs when a resistance overcomes the muscle tension so that the muscle actively lengthens. We see this as weight training when the athlete slowly lowers the weight to the starting position. This is commonly called negative. An example is when doing arm curls. You allow the biceps to relax slowly until you return to a straight arm position. Remember, you are not contracting the triceps to extend your arm, but rather slowly releasing your biceps muscle. The next section identifies facts and myths about fitness and answers those questions that are most frequently asked. This section will also provide a rationale for why some popular exercises fail the benefit to risk index. When they do fail the test, appropriate alternate exercises are provided. Everyone knows that physical activity and exercise is good for the human body. Unfortunately, in our zest to get fit, we can often hurt ourselves if we use outdated principles or are convinced by exaggerated claims. Many of us have grown up with faulty assumptions about exercise that can leave us vulnerable to celebrity endorsement and paid programming. Most paid programming has just enough truth and facts to seem plausible. Couple that with celebrity endorsements or airbrushed models, and it's no wonder that many fall for get-fit-quick gimmicks. One expert stated that at least 90% of exercise programs include some exercises that are as detrimental as they are valuable. The key when determining if an exercise is correct is, does it pass the benefits to risk ratio? The question to ask yourself is this exercise doing more harm than good? And is there a safer, more effective way to get the desired results? A common example is the traditional sit-up versus crunches. When you design a fitness routine, ask the following questions. Why am I doing this exercise? What is the benefit of this exercise? What are the risks of this exercise? How does it feel to do this exercise? How does it feel when the exercise is over? Can the same benefits be achieved with a safer exercise? If an exercise fails the above criteria, look for another exercise. An important concept to keep in mind is not to become complacent about exercise. It is critical to be mindful of proper body mechanics during a workout and pay attention to the body. Be mindful of every movement. Remember that only perfect practice makes perfect. You've heard it before. Exercise smart, not hard. Any exercise that has made it into a routine should give a maximum return on investment. Whenever you select an activity, exercise, or piece of equipment, keep in mind the following. Safety. Is it safe? Target muscle. Does it work the muscle you want it to work? Benefit versus risk. Benefits should outweigh risk. Biomechanics. Is it biomechanically correct? Selection of exercise. Does it fall in line with other exercises? Kinesthetic feedback. How does it feel? Harm versus hurt. Is it harming a joint? Time. Does it take too much time? And finally, compatibility. Is it compatible with the exercise program goal? High-risk areas include the neck, low back, shoulders, knees, and ankles. Pay close attention when implementing exercises that involve these areas, and remember good body mechanics. Neck problems can occur in an exercise environment when the activities performed cause excessive hyperextension. Eliminate fast warm-up motions, and do not combine neck movements. Avoid full neck circles, and use half neck circles, side to side, and front to back stretches instead. The majority of adults will experience back pain at some time in their life. It is critical to protect and stabilize the back during exercise. Never include any exercise that involves forward flexion and rotations at the same time. For example, windmill toe touches. Eliminate exercises that create hyperextension of the low back area, bending back at the waist. Use caution when doing any movements that cause lateral flexion of the spine, such as side bends. Also, be careful not to lean too much at the waist during lateral leg raises. The leg should only be raised 45 to 50 degrees. Toes should point forward, and the trunk should not move. Shoulder impingement is increasingly becoming a concern for exercisers. Use caution when raising the arms above the head. Movements need to be controlled, and the hands should be supinated, or palms up, if raising arms above shoulder height. Using hand weights with the arms fully extended can aggravate shoulder problems, and may cause elbow problems as well. Shoulders should be relaxed when performing arm exercises. There is a tendency to pull the shoulders up near the ears when exercising the arms. Also, encourage clients to keep the shoulder blades retracted. The action of the knee is to flex and extend. Eliminate movements that hyperextend or rotate the tibia. Keep soft knees during workouts. In addition, avoid twisting the body with the feet planted. Only include exercises that keep knees over the feet. In addition, the knees and toes should always point in the same direction. When performing an exercise using the quadriceps, remember that force rather than speed is better. Also, avoid overflexion of the knee joint during quadricep stretches. For example, bringing the heel towards the buttocks. By now, the average fitness aficionado knows about core stability or core strength exercises. Core strength is important for many reasons. As core strength increases, there is often an increase in the stability of the trunk and back. While attention to core stabilization and training assures safer and better lifting techniques, emphasis on developing stability and strength in the abdominal and back muscles should not diminish the importance of peripheral stability. As the age of the general population increases, so does the incidence of orthopedic injuries. Joint injuries of the shoulder, elbow, wrist, or knee often incapacitate or limit normal daily function in athletes and the general population alike. Stability training must go beyond core stabilization to provide total body joint stabilization. The key to successful training is to direct client attention to the major areas of the body as well as the lesser but still important aspects of the human frame. The shoulder joint is an amazing joint because it allows a person to gently rock a little baby or throw a 90-mile-an-hour fastball. The number of injuries to the shoulder joint warrants special consideration in training. If you can position the scapula in the right place and control its movement during both static and dynamic activity, the position of the glenoid, the acromion process, and the other entire joint structures are optimized. Hence, there is less risk of impingement and safer shoulder exercises. Performing rowing exercises such as the low pull with emphasis on scapular retraction can increase stability in the scapula platform and shoulder joints. The scapular muscles provide the positioning for inferior stability of the glenoid labrum for a snug-fitting humeral head. The rotator cuff muscles provide glenohumeral stability. Rotator cuff abduction or adduction exercises should also be an integral part of stability. The smaller muscles are often overlooked, creating an imbalance with the more developed deltoid muscles. A simple move such as a lateral raise above 90 degrees can compromise the integrity of the shoulder joint if such an imbalance is present. The knee is an engineering marvel. In general, female athletes can be more prone to knee injuries over male athletes, and orthopedic experts maintain that the increased Q angle is the cause. They suggest that the greater the angle from the hip to the knee, the greater the risk for knee problems. Knee stability exercises, for both men and women, can be done easily and without expensive equipment. Many exercise specialists recommend closed kinetic chain exercises to improve knee stability. Terminal extension of the leg is often a recommended closed kinetic chain exercise that engages the vastus medialis oblique muscle, or VMO. When the VMO increases in density and strength, it can add to the stability of the knee joint. Weakness in the area of the VMO increases instability of the knee. This exercise can be performed by standing on one leg and bending the knee slightly, from 15 to 20 degrees. To enhance the effect, stand on a foam block with the body weight shifted forward onto the ball of the foot as you bend the knee. The foam block activity has the added benefit of increasing ankle proprioception. The ankle is fundamental to athletics, as well as being a major player in ambulation, and a mainstay in the simple but vital task of standing. Stability training of the ankle includes proprioceptive and strength training. Simple exercises such as toe raises and walking on the heels are some basic active exercises that can foster ankle joint function. For the more limited client, adding ROM moves that include inversion, eversion, and flexion and extension are often a good starting point. As the client progresses, add exercises that will improve strength, PNF, and proprioception of the ankles. Wobble board exercises, including seesaw, pivot, and balance, can be added to these exercises. Proprioceptive training can improve dynamic balance. Some of the research in this area has shown that this type of training might prevent injuries and has been shown to decrease falls in the older adult population. Remember though, simple before complex. Welcome to the next lecture in your exercise therapy course. This lecture will provide you with rationale for why some popular exercises fail the benefit to risk index and provide safer alternates. Let's get started. The first exercise we are going to discuss is head circles, or exercises involving head rolling. Rolling may strain the supporting ligaments that maintain stability in the cervical spine. These exercises can aggravate impingement of the nerves. Neck extensions can also put pressure on the anterior arteries of the neck, specifically the carotid, which can cause high blood pressure and compromise blood flow to the brain. These risks, combined with degenerative changes that occur with aging, osteoporosis for example, leave individuals more susceptible to injury, especially if posture is poor. Instead, we want to slowly turn the head from left to right, or lean the head from side to side. Make sure to emphasize proper alignment of the head, neck, and shoulders. Standing toe touches should also be avoided. They run the risk for hyperextending the joint capsule and stretching the knee ligaments. In addition, they cause excessive pressure on the intervertebral disc in the lower back, which may strain the soft tissue structures. Rounding of the upper back is also discouraged. Strain on the back muscles is also created when returning to the upright position. Proper body mechanics instructs us to use leg muscles rather than back muscles. A way to adapt this exercise is to sit on the floor or in a chair and extend one or both legs out in front of the body. Keeping the back straight and knees slightly bent, slowly bend forward at the waist and reach towards toes. Bouncing during warm-up or stretching exercises is not good. Bouncing or stretching ballistically does not increase flexibility and actually causes the stretched muscle to contract and shorten, which may induce strain as well as micro tears in the muscle fibers. Instead of bouncing, slowly stretch to a point of mild discomfort and hold this position for 10 to 30 seconds. Studies on the hamstring muscle show that 20 seconds is optimal. Now let's discuss sit-ups. Straight leg sit-ups do not isolate the abdominal muscles and tend to primarily work the hip flexor. They do utilize the abdominal muscles, but they are not a good choice for the reasons mentioned. This technique encourages a hyperextended posture of the low back, or lordosis, and causes unnecessary strain to this area. Holding hands behind the head may contribute to forward head and kyphosis, as well as cause excessive pressure on the cervical area. In addition, holding one's feet during a sit-up is similar to doing straight leg sit-ups. The abdominal muscles are not the prime movers. The hip flexors are. An adaptation for these sit-ups is to lie flat on the floor, bend both knees, and bring heels as close to possible to the buttocks. Cross both arms across the chest and slowly tuck chin to chest and lift shoulders off the floor. It is unnecessary to go up further than halfway. Full squats or deep knee bends should be avoided because full squats cause excessive stretching of the ligaments of the knee and may pinch the joint cartilage. Once the ligaments of the knee have been stretched, they cause instability to the knee joint. When squatting, it is better to not squat beyond a point in which thighs are parallel to the floor. Double leg lifts, like straight leg sit-ups, work the abdominal muscles and hip flexors and are very difficult to do correctly. They encourage a hyperextended posture and create excessive pressure in the lumbar area. There are much safer and better alternatives. If your goal is to increase abdominal strength, perform sit-ups or curl-ups with both knees bent, feet flat on the floor, arms across the chest, and bring heels as close to the buttocks as possible. Hurdler stretch should also be avoided. With the leg in this bent position, the knee ligaments are stretched excessively, risking unnecessary damage. Instead, place both legs in front of body and stretch forward at the waist, keeping the back straight. Or, bend one leg and place the bottom of the foot on the inside of the thigh and reach towards toes. The trunk twist puts strain on the lumbar area and possibly the knee. Torque generated by the twisting action in the trunk causes considerable strain to the knee and the lower back. Leaning left and right in a sitting position is a better option for this exercise. Isometric exercises are contraindicated for those individuals over 40 years old, or those individuals with a history of cardiovascular disease, especially high blood pressure. Isometric arm exercises actually increase blood pressure. To minimize the risk of unnecessary high blood pressure, exercise with a comfortable amount of weight, breathe properly, and perform the exercise through the entire range of motion. Active hyperextension of the back decreases compression of the intervertebral discs and is used for disc patients, but it increases irritation of the facet joints. For active strengthening, lie face down with a pillow under the hips to prevent lumbar lordosis and a towel roll under the forehead to prevent neck strain. Stretch arms overhead and lift one arm and the opposite leg and hold. Lastly, avoid immediate rest after intense exercise because it will prevent the adequate return of blood to the heart. Continue with low-intensity exercise, such as walking, to encourage proper return of blood to the heart, preventing any blood pooling effect that may occur in the lower extremities. Here is a list of exercise do's and don'ts. Do carry identification when exercising. Do invest in good shoes and socks. Your feet and knees are worth it. Do listen to your body. If it hurts, stop. Consult a physician for unusual or continuous pain. Do check your heart rate before, during, and after exercise. Don't exercise in rubberized or plastic clothing. Don't bounce when stretching, and stop a stretch if it hurts. Don't squeeze a week's worth of exercise into one day. Do spread exercise sessions evenly throughout the week. Make sure to alternate hard and easy days. Don't overestimate your body's capacity to exercise, and don't underestimate it. Remember, your body is designed for movement, but do let it adapt slowly and gradually. Finally, don't hold your breath during exercise. When working with clients, keep the following in mind. Do not tilt the head towards the back. For example, looking towards the ceiling. Avoid positions in which the torso is bent forward with the legs extended, such as toe touches. Gently stretch without bouncing. Do not overextend or lock out the joints. Do not force or pull hard on any joint or part of the body. Keep your knees in line with your feet. Do not let the knees go forward beyond the toes. Avoid weight on the legs if the angle of knee is less than 90 degrees. Avoid or use caution with trunk rotation and bending. Keep movements controlled and maintain good posture. The following are the vascular considerations covered in this lecture. This list is also included in your text. Keep the head above heart level until you are cooled down. Move slowly between positions of lying down, sitting, and standing. Perform a gentle, thorough warm-up of 5 to 15 minutes and a cool-down of 5 to 15 minutes. Avoid isometric exercises in which you apply force without moving the muscle. For example, pushing against a wall. Stay well hydrated by drinking plenty of water before, during, and after exercise. In this last slide, we are going to discuss safety considerations. Too little exercise is being conducted when the heart rate is below the target range. If there is little increase in the frequency or depth of breathing, if there is no or little muscle fatigue, and a sweat is not broken. These are all indications that the exercise program needs to be adjusted to meet these marks. Too much exercise needs to be monitored as well. A heart rate above target range, panting, the inability to hold a conversation easily, stiffness or soreness days after exercise, and fatigue lasting over a day are all signs of too much exercise. It is important to refer your client to a doctor when symptoms are more severe. Chest pain, tightness, or abnormal heartbeats, painful breathing during exercise, severe muscle, joint pain, or swelling lasting more than a few days, as well as dizziness, lack of coordination, and confusion should all be directed toward a doctor. This concludes this week's lecture series. Next week, we will discuss chronic, cardiovascular, and metabolic conditions. Welcome to your next lecture. In this lecture, we will start with a quick overview of chronic conditions, and will then begin discussing cardiorespiratory conditions. Let's get started. Regardless of age and physical condition, functional fitness is a major factor in maintaining health and reducing disability. Almost any condition can be improved, or at least maintained, through regular, sensible exercise, as long as the physician is informed and the individual follows the doctor's recommendations. We now have documentation that everything from arthritis to Parkinson's disease can benefit from appropriate exercise. Don't let your clients be limited by their physical problems, only by their expectations. It is important to note that chronic conditions differ significantly from acute episodes. Chronic conditions usually cannot be cured, and often have an uncertain prognosis. Another far-reaching implication of a chronic condition is how it predetermines a person's life in psychosocial, financial, or medical ways. Many times, chronic conditions lead to deficits in activities of daily living, and often interfere with a person's quality of life. Approximately 5.6 million people over 65 years of age have at least one deficit that limits how they perform activities of daily living, such as dressing, getting around, using the bathroom, cooking, and eating. Improved functional fitness improves a person's ability to participate more fully in society, lessens the burden on family and caregivers, and reduces medical costs. Functional physical fitness is defined as the fitness that improves a person's ability to live a fuller life. Exercise does not have to take the form of physical therapy to be therapeutic. As previewed earlier in this course, regular exercise not only improves functional ability and affords physiological benefits, it also yields improvement in the psychological and social areas of a person's life. This slide reviews common health problems seen among older adults. In training clients with cardiovascular issues, you will most commonly see high blood pressure, or hypertension, and a number of heart diseases like angina, arteriosclerosis, and congestive heart failure. The most common neurological diseases you may come in contact with include Alzheimer's disease, stroke, and Parkinson's disease. Arthritis, osteoporosis, and bone fractures will top out the list for the most common musculoskeletal problems. Your text provides a more complete table. As we've discussed throughout this course, exercise brings many benefits. Clients who engage in regular physical activity see improvements in muscular strength and endurance, flexibility and mobility, cardiovascular fitness, coordination and balance, and a decrease in pain. The psychological benefits from these improvements promote a stronger self-image, increase self-confidence, and reinforce the reality that the client can do more. While physiological benefits are important, the psychological benefits and social benefits are equally valuable to your client's success. Social aspects of exercise are generally the reason why people stick with an exercise program. A few of the social benefits of exercise include improved compliance and adherence to the program, provision of a new activity that the client enjoys, an opportunity to make new friends, and a healthy, positive way to spend time. Teach your clients when exercising to think about the benefits of their successes, no matter how small, rather than the consequences of any failure. Most people give up on exercise too soon without giving it a fair chance. It may have taken the client a long time to get into the condition they are in now, but if they start slowly and set themselves up to succeed, they can and will do it. Most people expect results now, and thus get sore and quit too soon. Assure clients that if they stick with the program for at least 6 months, they will see change. Positive changes include feeling better, not getting as tired, or even developing a new group of friends and workout partners. If you are going to be successful with exercise instruction, you need to teach your clients to exercise in a pain-free range and learn to listen to their bodies. Often, we deal with clients and patients who are returning to physical activity after surgery, illness, injury, or an extended period of inactivity. Exercise, when done properly and prudently, will generally have a positive outcome. Exercise is therapy for the mind and body. However, it is our job to make sure it is done within the standards and practices recommended for adults. It is also important to remember that the physicians and the physical therapist protocols supersede any exercise program we have developed. If you have concerns or disagreements about what a doctor or physical therapist prescribes for a client, phone the doctor or therapist to discuss the rationales. As said earlier, your role is to be a team player in the client's continuum of care. Some exercise is better than none. On days your client does not feel like exercising, try to get them to do 5 to 10 minutes of exercise. Maybe 2 or 3 of their favorite exercises instead of a full workout. It is better to do a little of something than a lot of nothing. It is also better to do 5 minutes of gentle exercise daily and be pain-free than to do 30 minutes of hard, vigorous exercise 3 times a week and be sore. Try to set up a positive addiction to exercise. It is important to note that many of the health issues common with older age respond favorably to regular and prudent exercise. It is critical to keep in mind that your client is an individual to be respected and cared for, and not just a person with a bad back or a bum knee. Our mission is to help the client function at optimum efficiency. One last topic before we start delving into specific chronic conditions. Communication. Communication is an important component of your client's safe return to activity. A common mistake people make is to begin an exercise program without first consulting a physician or physical therapist. A doctor or physical therapist can help set any movement limitations for the body, as well as prescribe appropriate exercises and set realistic goals. It is the client's responsibility to communicate these movement limitations and goals to you. Once you are aware of the client's condition, you can ask the client's permission to follow up with a phone call to the doctor or physical therapist. This way, everyone involved with the client's return to physical activity is aware of his or her condition, and all work together to provide the safest and most effective program. Be sure to have the client grant permission to the medical professional to discuss the condition with you. Physicians and physical therapists must have authorizations on file in order to discuss a patient's condition with a third party. This next section will discuss the cardiorespiratory conditions your clients might express. In all of these cases, a doctor must be consulted prior to program design and implication. Many adults have high blood pressure, also known as hypertension. It is believed that hypertension is the 3rd most common chronic condition in the United States, right behind sinusitis and arthritis. Generally, people with high blood pressure will get cardiovascular disease after 65 years of age. Fortunately, most people with hypertension are classified with only moderately high blood pressure. That means that the lower number, the diastolic pressure, is within the range of 90 millimeters of mercury to 105 millimeters of mercury. Persons with mild hypertension are often treated with a drug-free approach, which includes losing weight and participating in aerobic exercise. Most people have what is called essential hypertension, which means that the cause is unknown. Other people have what is called secondary hypertension, caused by renal or other endocrine factors. Clients with high blood pressure should avoid heavy resistance training and not hold their breath when exercising. They also need to be cleared by a physician before starting an exercise program. Numerous studies have shown that aerobic exercise has a positive influence on lowering blood pressure. Aerobic exercise includes such activities as walking, swimming, and bike riding. Dr. Cade, professor of medicine at the University of Florida, suggests that hypertensive individuals start slowly and progress over time. Dr. Cade says, You don't have to run to get good results. Walking does the same thing as running. It just takes longer. Exercising with light weights may be acceptable, but check with the physician before starting. Emphasize warm-up and stretching portions of the workout, as well as using a prolonged cool-down session. Never have the client stop suddenly. Always keep them moving after vigorous exercise until heart rate is close to their pre-exercising resting level. Here are some precautions for exercise. Focus on exhaling with each repetition of an exercise. Emphasize muscular endurance versus strength. Perform a minimum of 10 to 15 repetitions of each exercise with a lighter weight. And concentrate more of the program on lower extremity exercises. Upper body work is good, but pressing too much weight overhead tends to elevate the blood pressure. In contrast to those with high blood pressure, some older adults are prone to low blood pressure, also known as hypoextension. Low blood pressure can be problematic, resulting in dizziness or a feeling of faintness if the individual stands up too quickly. Many times, hypotension is the result of tranquilizers, antidepressants, or medications used for hypertension or heart disease. The client should consult their physician if experiencing lightheadedness when getting up. The following considerations should be made when designing an exercise program for a hypotension client. Do not stand in one spot too long without moving. Blood will tend to pool in the lower extremities, thus causing lightheadedness or dizziness. Do not get up too quickly from a lying or sitting position. The circulation of blood and oxygen to the brain may not be as quick. Many situations throughout the day can be stressful for all of us. Learning to deal effectively with these stresses involves developing an awareness of the causes, as well as enacting a plan to reduce or eliminate any negative effects. Physical activity plays a large part in helping the body and mind adapt to stress. Based upon each individual's needs, one or more of the following activities can contribute to helping your client control stress and its effects. Exercises that focus on controlled deep breathing may help to lower blood pressure and quiet the mind. Tense muscles contribute to poor posture, pain, and fatigue. Stretching and flexibility exercises allow the body to relax. Vigorous activity is useful as a way to release anxiety. For example, riding a stationary bicycle, walking on a treadmill, performing calisthenics, etc. Your client can also do things apart from your time with them to help reduce stress. Some of those things include getting a therapeutic massage, attending yoga, tai chi, or meditation classes, listening to audio of deep relaxation and guided visualization, attending group self-awareness or guidance classes, developing a good nutritional program, finding time for adequate rest, and developing a plan to ensure a good night's sleep, or even participating in a hobby or other recreational pursuit. Okay, moving on to heart disease. There are many different types of heart disease. Conditions include high blood pressure, atherosclerosis, coronary artery disease, angina pectoris, and congestive heart failure. Studies show that people who are physically active have less heart disease than their sedentary counterparts. Fit people who do have a heart attack have a higher survival rate, and regular exercise helps to reduce the risk of acquiring heart disease. Regular exercise is also used to rehabilitate a person who has already suffered a cardiac event. A sensible and prudent exercise program may lower blood pressure and increase exercise tolerance, as well as lower total cholesterol while increasing the desirable protective higher density lipoproteins, HDL cholesterol. Heart disease is the leading cause of death in the U.S. for both men and women, and many cardiologists contend that the after effects of a heart attack are more devastating than the damage to the heart. Many people who have had a heart attack are afraid to live, in fear of dying. This is why a sensible and regular exercise program is so important. A guided cardiac rehabilitation program helps your clients gain the ability to exercise independently and feel more confident about his or her health. Exercise has many positive cardiovascular effects on the body. It assists in ridding the body of excess fat and weight that place undue stress on the heart, eases stress and tension, slows the aging process, helps to reduce fats in the bloodstream, improves peripheral circulation, makes oxygen delivery more efficient, and can reduce blood pressure. The key to a healthy heart includes eating right, eating lean, reducing stress, keeping blood pressure under control, exercising aerobically, and, if applicable, eliminating smoking. When creating an exercise program for a client with heart disease, it is important that you get approval from the client's physician. This point cannot be stressed enough. The road back from a heart attack is a slow and steady one. Clients cannot afford to overdo it. Watch for chest pain, nausea, and pain in the arm or jaw. If any of these occur, call 911 immediately. The following precautions should be taken when training these clients. Never allow client to hold their breath. We have already discussed how this can increase blood pressure. Make sure the client focuses on improving health and not on competing. Get a physician's approval prior to starting and follow the orders exactly. Ask the physician how often and how hard your client should exercise. Also, encourage your client to participate in a supervised cardiac rehabilitation program prior to engaging in your program. If a client has angina, make sure they carry their medication at all times. If your client is on beta blockers, exercise heart rates are not useful for measuring the level of exertion. Use the talk test. If the client can't talk, slow down. He or she is moving too fast or too hard. Most physicians will encourage their patients to do gentle aerobic exercise. A walking program of 5 minutes once a day is a good way to start. Then progress to 2 times per day. If walking is hard on the client's joints, try stationary biking, water exercise, or swimming. Welcome to your next lecture. In this lecture, we will finish discussing cardiorespiratory conditions with topics on COPD and asthma. We will then move on to metabolic conditions. Let's get started. Chronic obstructive pulmonary disease, also known as COPD, is a progressive disease of the lungs characterized by the destruction of the alveoli, retention of mucus secretions, narrowed airways, and respiratory muscle weakness. Common conditions grouped under this heading include bronchitis, asthma, emphysema, and sometimes allergies. These conditions make respiration difficult. The long-term effects can lead to cardiac instability and arrhythmia. Research shows that a slow, progressive, general conditioning exercise program that ultimately leads to good aerobic fitness improves exercise and activity tolerance. This improvement is believed to be due to improved efficiency of the muscles involved in breathing and lessens anxiety when shortness of breath or dyspnea occurs. The goal of breathing exercises is to improve ventilation, improve strength and endurance of respiratory muscles, maintain and improve chest and mid-back mobility, increase effectiveness of cough mechanism, and correct inefficient breathing patterns. An effective way to relieve shortness of breath is to have the client sit in a relaxed position leaning forward, resting their forearms on their thighs, and breathe gently. Another way is to have the client stand up, lean forward using the support of a table or other surface, and breathe gently. When creating an exercise program for individuals with COPD, you must start at a very low level of activity. This level of intensity must be based on the physician's recommendations and the individual's abilities. Never allow clients to overextend themselves. Moderate the pace depending on how the client feels. Have the client learn to use relaxed pursed lip breathing, which we will discuss in just a minute. Pursed lip breathing slows the rate of exhalation and increases the comfort level. Also, intermittent activities that allow recuperative time are ideal. Research shows that short walks, followed by recovery of 15 to 20 minutes, twice a day, 5 times a week, work well. A stationary bike is another option, allowing for safe and comfortable exercise. Note that non-weight-bearing exercises are easier on the cardiovascular system and are a good place to start. Chest mobility is also important. Your text outlines a few exercises that are used to improve chest mobility. Please take the time to review them after this lecture. As with any condition, there are a couple of exercise precautions that need to be addressed. Your client should never force expiration. Expiration should be relaxed and passive. And the other precaution is to avoid hyperventilation. Breathing is an automatic process, yet we control our pace at will. Focusing on proper breathing techniques during exercise is extremely important for blood pressure control. Clients should never hold their breath. Rather, exhale while exerting any strenuous effort. Shortness of breath is an indication to slow down. There are 2 breathing exercises that are used to treat persons with COPD. These breathing exercises are pursed lip breathing and diaphragm breathing. They are designed to help clients learn to breathe more easily. When individuals with breathing difficulty become short of breath, they may feel anxious and tense. They may begin to breathe rapidly and shallowly, and their air sacs will not have enough time to fill or empty completely. The harder they work to force the used air out of the lungs, the more the small airways collapse. They end up feeling worse. Breathing techniques should be practiced several times during the day until they become a habit. The purpose of pursed lip breathing is to prevent the airways from collapsing and to avoid trapping stale air in the lungs. This is done by creating a resistance to airflow through pursed lips. Breathing against this resistance increases pressure in the airways and prevents them from collapsing. Direct your clients to perform these steps. Assume a relaxed position, either sitting or semi-reclined. Inhale slowly through the nose, keeping the mouth closed. Purse the lips in a whistling position. Exhale slowly and evenly through the lips. Try to exhale at least twice as long as you inhale. For example, 3 seconds in, 6 seconds out. Repeat for 4 breaths and then rest. Do not exhale too forcefully or to the point of discomfort. Pursed lip breathing should be used when exerting oneself or when one feels breathless. Because this technique is used with other breathing exercises, it is important that it is learned properly and practiced often. The diaphragm is the major muscle of breathing. Remember that in COPD, trapped air pushes down on the diaphragm and flattens it. Because this flattened position makes it difficult for the diaphragm to work, the upper chest and neck muscles try to help out. However, these muscles require more oxygen to work and are not as efficient as the diaphragm. The diaphragm breathing exercise will increase the mobility and strength of the diaphragm. Have the client locate the diaphragm by placing the palm of the hand on the center of the stomach. Then sniff quickly. The client will feel the diaphragm go up. Have the client follow this procedure. Lie down on a level surface with a pillow under the knees to support the back. Place the palm of one hand on the upper abdominal area, above the belly button and below the rib cage. Place the other hand on the upper chest to feel for movement of the upper chest muscles. Exhale slowly through pursed lips and gently push inward with the lower hand. Inhale slowly and deeply through the nose. Asthma is classified as a reversible, either spontaneously or therapeutically, obstructive airway disease, resulting in the sudden onset of muscle spasms, swelling, and the presence of mucus in the tracheobronchial tree. It is caused by a hyperirritability to a variety of stimuli, such as inhalants, ingestants, environment, and exercise. Exercise-induced asthma, or EIA, is brought on by sustained exercise such as running or bicycling for longer than 6 minutes. EIA becomes increasingly severe as the duration of exercise increases, with the response greatest after 6 to 8 minutes of aerobic activity, and reduced FEV1 during and after cessation of exercise. FEV1 refers to the forced expiratory volume of air in 1 second. It is a flow rate measuring the amount of air that is expired in 1 second from a maximal exhalation. It is usually expressed as a percentage of the total amount of exhaled air. The physical characteristics of persons with asthma are weak abdominals, weak upper back muscles, rhomboids, and loss of flexibility in shoulders, lower back, and hamstrings. Symptoms of asthma include a cough or hack due to increased mucus, wheezing and dyspnea, leading to difficult exhalation, and severe bronchial constriction to the point of cyanosis, which is an extreme medical emergency. If your client experiences an asthma attack, Have the individual sit and attempt to relax. Provide a glass of warm water to break down mucus. Have the individual use his or her medication. And if breathing is severely impaired, call 911. This concludes our discussion on cardiorespiratory conditions. The next topic is going to be on metabolic conditions. We will start with diabetes mellitus and wrap up with obesity. When a person has diabetes mellitus, the person's body doesn't provide enough insulin. Insulin is a hormone that regulates the amount of sugar in the bloodstream. There are two types of diabetes mellitus, type 1 and type 2. Type 1 diabetes is insulin-dependent diabetes, formerly called juvenile diabetes, where the body's immune system destroys insulin-producing cells, and insulin needs to be injected into the bloodstream. Type 2 diabetes is known as non-insulin-dependent diabetes, formerly called adult-onset diabetes, where the body does not produce enough insulin. With type 2, diet, exercise, and oral medications usually work well, so insulin injections are not needed to control blood glucose levels. Most people who develop type 2 diabetes are over 40 years of age and are commonly obese. However, studies find that young children are being diagnosed with type 2 diabetes, and that this trend is increasing. Regular exercise can help a person with type 2 diabetes to stabilize the condition by decreasing excess fat and weight, decreasing the need for insulin, lowering cholesterol, and avoiding further complications. Having diabetes or being at risk for diabetes is not an excuse to avoid exercise, but rather a reason to exercise. Exercising vigorously just once a week reduces a person's risk of type 2 diabetes by 23%. According to an article published in JAMA, the Journal of American Medical Association, a study of over 21,000 male physicians aged 40 to 84 found that the more one exercises, the lower the risk of diabetes. Exercising vigorously from 2 to 4 times a week reduced risk by 38%. And exercising 5 or more times a week reduced risk by 42%. Lack of exercise contributes to as much as a quarter of the cases of type 2 diabetes, according to the authors of this study. Exercise is extremely beneficial for clients with type 2 diabetes, but like every other medical condition, always consult your client's physician for specific recommendations and precautions before you begin. This slide lists some general cautions for diabetics. These precautions serve to inform your exercise programming, but are not intended to replace or override the precautions of your client's physician. Diabetics need to protect their feet and should avoid activities that are stressful to the feet, such as jogging. Diabetics will always need to dry between the toes after bathing, and always wear suitable footwear to avoid blisters. When blood sugar levels are above 300 milligrams, exercise is out of the question. Diabetes can lead to retinopathy. Retinopathy is a disease of the retina of the eye that can lead to blindness. Diabetics with retinopathy should avoid intense exercise such as heavy weightlifting, sprints, and other vigorous activities. Now let's go over some exercise guidelines for diabetics. The exercise heart rate should be between 50% and 70% of the maximum heart rate. Consult the client's physician regarding the correct level of insulin needed when exercising. Persons with hypoglycemia, low blood sugar, or too much insulin in the blood should have easily digestible carbohydrates, orange juice for example, available at all times. A diabetic should never exercise on an empty stomach and should stay hydrated. Lastly, make sure to allow for proper warm-up and cool-down. As a trainer, you need to be alert to signs of distress. The following are signs of low blood sugar: double vision, fatigue, excessive hunger, increased heart rate, excessive sweating, and trembling. Signs of a diabetic coma include increased thirst, stomach pain, dehydration, increased urination, faulty breathing, drowsiness, and nausea. As a safety precaution, encourage clients with diabetes to exercise at predictable times to minimize blood sugar fluctuation. Also, encourage them to exercise with a buddy when they are not training with you. Obesity has reached epidemic proportions in the United States and is considered a leading cause of heart disease. For the general population, obesity can be defined as a body mass index, BMI, above 30. It is important to remember that although BMI correlates with body fat, it does not directly measure body fat. As a result, some people, such as athletes, may have a BMI that identifies them as overweight, even though they do not have excess body fat. This is because muscle is heavier than fat. The person may weigh more than is indicated on standard height-weight charts, but is actually in good shape. Therefore, remember that body composition, not just BMI, is an important factor in determining risk factors. Obesity is a serious problem and is associated with numerous medical issues. Excess fat places additional demands on the heart and lungs. People who are obese have increased incidence of hypertension and diabetes, high levels of cholesterol, and poor ratios of high-density and low-density lipoproteins. Another side effect of obesity is the stress it places on weight-bearing joints of the body. If an obese person could lose weight, there would be less stress on the lower back, hips, knees, and ankles. However, if it hurts to exercise, then the person won't exercise. Thus, they get pulled into a vicious cycle of inactivity and further weight gain. To begin the process of returning to a healthy weight, an obese client needs to increase activity levels and decrease caloric intake slowly to ensure that he or she will stick with it. By cutting back on only 50 calories a day, that's just half of an apple, and increasing the activity level, a person will lose at least a pound a month. Well, one might say, but I've got 30 pounds to lose. However, if all one does is cut 50 calories a day, in 1 year, he or she will have lost at least 12 pounds. Most people who lose a lot of weight in a short period of time gain it back. But if you lose 1 to 2 pounds per month, there is a good chance it will be gone forever. Successful weight loss programs require lifestyle changes of eating less and moving more. Remember that excess fat is just unused energy. Like with any condition, clients with obesity will need to consult a physician to obtain a medical approval to exercise. It would also be beneficial to see a registered dietitian so that a balanced diet can be created. Obese clients should not go on crash diets and should avoid weight loss gimmicks. They also need to avoid exercise in hot climates, as well as high-intensity exercise. Monitor heart rate and blood pressure. When creating an exercise program, you should start clients very, very slowly. Try starting them off by walking slowly 5 minutes per day and progress by 1 minute a week until they can walk pain and stress-free for 20 minutes. If they are open to it, water exercise or stationary biking are also great alternatives to walking. Ideally, you want to get your client to do something aerobic 3 to 5 times per week. So to wrap up our discussion on obesity, remember, it is possible to be fit and technically overweight because muscle weighs more than fat. Remember to set realistic weight goals for clients. Encourage clients to introduce more overall activity into their lives. And finally, be prudent about serving size and quality of food. This concludes our lecture on cardiorespiratory and metabolic conditions. See you next time. See you next time. See you next time.